All right, my name is Dustin Anderson. I'm here to talk about my CMA Integrative Health Implementation Project for ATTR 755, Clinical Experience 1. Um, I chose mental imagery to help this patient. Um, just to give a little bit of background about the patient and how he came to come to the athletic training room. Um, just for the sake of this, it's a lieutenant colonel. I'm just going to refer to him as Lieutenant Colonel Z. Um, 2 weeks prior to seeing me, he was doing an obstacle course. Went to go up a wall and felt a pop in his calf, and he went to CTMC, which is just the little site hospital for the 199th. Seeing the doctor, got a profile limitations of no activity, go see physical therapy, but he knew about us, about the athletic trainers, and he's a big proponent for athletic trainers in the military because he was physically active, played soccer, wrestled, everything else in high school, went to West Point, and was pretty familiar with what we could do, and knew we were a little more accessible than PT. He didn't want to wait 2 weeks for an appointment and be behind the eight ball per se. With his care, he came in, seen me, did the evaluation, came to the conclusion that he had a good grade 2 medial gastroc strain, and we started to work with him. I've been working with him for about 2 weeks, then got reminded that I still had to do this project. So I started talking to him about what he might be willing to do, or if he would be willing to help me with my assignment, and he was more than happy to help. I told him that I wanted to incorporate some mental imagery into his rehab. More at the beginning, more for pain control. Then, as we went along, more for returning to activity. And he was fine with it. He was pretty good with coming in for rehab and everything else. He came in 3 days a week, so I figured he'd stick with it pretty well. The reason I chose mental imagery is I think it's pretty powerful. Your mind can be your best friend or your worst enemy. I've used mental imagery and meditation pretty successfully in the past. Especially when I was into bodybuilding, playing sports, and everything else. I think it's a good idea to walk through situations before they actually happen. I used it in undergrad for thinking about graduation and studying more, and sort of told him about my experiences with it, and he seemed to be a little bit more on board when he knew that I had success with it. So what I wanted him to do at the beginning was supplement it in at night before he went to bed, especially if his leg was hurting, just so he could get used to it. And the script that I gave him when I started out was just for him to lay there in a nice quiet place, just 10 to 15 minutes, and think about the muscles relaxing in his legs, the pain going away, no pain at all, in his mind, moving his calf back and forth, and when he was moving it back and forth, not to be thinking about pain, just a nice smooth motion, just a nice normal calf motion. At the beginning, I think it was a little difficult for him to do it because, again, he was going to do it to help me out, but I think he needed a little convincing that it could help. As far as measuring it was really hard. I didn't find any good like prompts or anything else for mental imagery or anything like that. So I went with more of a patient's perceived usefulness of this. So every time he came in, we just did a visual pain scale, with the typical smiley face, like the face is straight, and frowny face, just those typical things in his perceived level of function. And I sort of came up with my own way to measure it. I asked him if he thought, I asked basically 3 questions, if he thought the mental imagery was helping. And it was sort of like a like heart scale with that one, 0 to 5. and it fell on those things. Asked him if he thought his performance was increasing or rehab was getting better. Performance will come in later. Again, Likert scale. And just ask him if he perceived his pain as lower. Again, with that Likert scale, 0 to 5. With it, I would have to say that he, in the beginning, I didn't really see good results with it. With him, I seen better results when we got to the performance aspect of it. So I still kept the same questions in there, but when we started doing more sport-specific drills, I had him start to visualize the drills in his sleep, more specifically soccer drills. He loves to play soccer with his sons and sort of teach them new drills and everything else. And we just came up with a basic cone drill that we would do in the athletic training room. So about 5 weeks into it, we just started walking through the drill, so he would get a good just a motor learning response with that one. So how it changed when he went to sleep was he thought about doing the drill, then he thought about doing the drill without pain, then he started thinking about doing the drill at a faster pace, then he started thinking about kicking the ball around with the drill, then like he wasn't even hurt with the drill. He said that he felt like his performance did increase with using visualization for that. But again, I didn't find any good ways to measure the effectiveness of mental imagery with that one. And I don't know if it was skewed with the perceived function and the visual pain scale, if it was just the rehab that we were doing that caused this pain to go down or not. I would like to think it was a combination of both, but I'm sort of biased with that one. So I worked with him for around 8 weeks. Then we sort of weaned him off of rehab, and he got back to normal activity and everything else. Pain and swelling went down, function went up, strength went up. And then at the end of it, I sort of just sat down and had a debrief with him and told him, that he's progressing well. We really didn't see him anymore. Then I wanted him to give me feedback on, mental imagery and if he would use it in the future or if he would use it with his sons or anything else. He said a couple of times when he was just in that nice, quiet place, he went to sleep. He was just thinking about it. He was nice and relaxed. And again, I don't know if it really helped him or not with anything. The literature on it is pretty inconsistent. It's not what you would call high-level evidence with anything. I told him about a book that I read that I think would help him. It's called Increasing in Excellence, and it was wrote by a sports psychologist, and how elite athletes perform, their mental attitude towards things, and I think he's got it. I haven't talked to him since I've been at the DAT weekend, but he said he had it on Amazon, so I don't know if he's ordered it from Amazon. I don't know if he's got it yet or not. Some ways that I can see this working with the military, there's got to be some buy-in, though. Especially if let's use IBOLC, for example. It's just the Infantry Basic Officer Leadership Course. If we could use mental imagery for, how they have to clear a room, or if they've got to learn if they're learning to shoot, seeing the target, and everything else, I think that would be beneficial. But again, there's got to be a buy-in on the command level with anything. And I think it was pretty cool that I got to do it with a lieutenant colonel and got his feedback with everything. As far outside the military setting, I think it is beneficial for athletes because they get to put themselves in that situation before it actually happens. I think it's good for rehab because they're just going through the situation in their mind. And it could be a way to get them over fear avoidance with anything. And I think that was one of the things that helped Lieutenant Colonel Z. Was he was very skittish about moving without walking with a limp, and I would like to think that the mental imagery and the techniques helped him get over those fears. But again, it was hard. I really couldn't measure it, and it was hard to see, hard to tell if he really got any benefit from it. Um, in the future, how I like to put it into my clinical practice is, come up with a script. You could come up with a script for ankle sprains, lateral knee pain, shoulder pain. I would have to work with Dr. Sefton. I think there's some good people at Auburn University that do this for a living and know a lot more about it than I do. And it would be really cool if I could give someone a handout about mental imagery techniques, because we give them handouts for like lower body stretching, ankle rehabs, and everything else. I think it would be a good little thing for them to do. But again, I'm sort of biased because I've did it in the past and I've seen good results with it. But for this project, I think if I would have been a little more on top of it and not had to have a reminder that it was due, I could have I could have got more people. It could have been more thought out and better planned with anything, and I could have had a little bit more time to see if there was a good prom to measure the effects of mental imagery and what populations it worked with and everything along those lines. But I think it does have a place, and in the future, I'm definitely going to try to put it into clinical practice. Even if I get out of the military setting, like I said, I think it would be good for athletics, or even if you're working in a clinic, it may be a good way to help with pain management. There's basically no limit to what you can do with it. It's just trying to find a place and trying to get people to buy into it. And that's the hardest thing that I've seen to do, is to get people to buy in to mental imagery and its uses and its effectiveness with helping them along the way in rehab and their goals in life. Thank you for your time.